So just resuming from where I left. So what are the other treatment options for children when they are moved to step 4 and beyond? See, leukotrienes, that is Montelukast, is just an add-on therapy to doubling the dose of inhaled corticosteroids. What we can do is sometimes for a week or so, we can add low dose oral corticosteroids in addition to the inhaled corticosteroid and Montelukast. Beyond 4 years, you can consider children. Beyond 4 years, you can consider LABA for children, as it is it is indicated in them, and temporarily you can increase the frequency of inhaled corticosteroid. That is your Budicort till the symptoms resolve. For example, if you are giving Budicort 100 twice in the morning and twice in the night, you can increase it to even 4 times a day. You can increase to around 4 times a day for a week or so till the symptoms comes under control. So these are the 4 options on step 4 therapy, but it is referral beyond step 3. So moving on to the next slide. So will my child have asthma? This is a very important question which we have to answer to parents. So this is the modified asthma predictive index, which has been done by a study in 2010-11 by Tucson study. See, they have classified this as major criteria and minor criteria. So major criteria are parental asthma, eczema, atopic dermatitis, inhalant allergen sensitization. Take a strong history, allergy history, and whether a skin prick test should be done in this child. Minor criteria are allergic rhinitis, wheezing apart from cold, that is without a URI the child has wheezing. Whenever peripheral blood eosinophilia is more than 4% and whenever there is food allergy. So if there is one major criteria or 2 minor criteria, then we call it as asthma predictive index positive. Asthma predictive index positive means they have 5-fold increase risk of having asthma later on in life. Asthma predictive index negative means they have around 80 to 90% that they may not develop asthma later on in life. So this is the current asthma modified asthma predictive index. So every child needs to have a written asthma action plan. So when you send a child home on inhalers, you have to tell her how to recognize and attack. Tell the mother that when the cough increases, you should start whenever the cough is cough enhance, then you should consider using a SABA. Emphasize the use of SABA whenever the cough starts increasing. Depending on the frequency of the cough and severity, you can time help the mother to time the SABA therapy, either second hourly or fourth hourly. Always provide emergency numbers of the hospital or the ER department for them to contact. So when they have to contact is whenever you have to arrange for immediate review if the SABA use is needed third hourly. The SABA is definitely needed third hourly. You have to have for an immediate review in the emergency room. Now, what about parent-initiated oral corticosteroids? Oral steroids initiated by the parent herself at this step. In an Indian scenario, it commonly happens, but it is not recommended. So this is the written asthma action plan which should be given. So finally, last slides. What is the diagnostic algorithm? So you have a preschool wheezer, under 5 wheezer. You have with risk factor, we may be episodic. In that case, you give SOS SABA and educate. You have SOS SABA and educate. If you have a persistent wheezer or recurrent multi-trigger wheezer, you have to start low dose inhaled steroid for them along with SABA SOS and decide double the dose if there is no response. And refer when there is no response to doubling the dose of ICS. So preschool wheezer, episodic or multi-trigger, and decide over time whether they change from one phenotype to other. What I mean is, it is a changing phenomenon. What a child who was episodic today, after a year or so, might become persistent or multi-trigger recurrent wheezer. And a multi-trigger wheezer can also have symptoms which are settled down by beyond 5 years of age. So there can be crossing over of phenotypes. This is the common algorithm which we follow. Now, what is the take-home message? See, classify and recognize the pattern. Episodic, multi-trigger, with risk factor, without risk factor. Time-based. Tell them they belong to this pattern now. They can change or evolve over time. Always check, correct, and confirm the inhaler therapy, that is your device dose, everything is correct. Always rule out mimics and rule in asthma. Step 3 and beyond, consider referral. Give your time and educate the parents. Be very less than 6 months. Be very in starting an ICS, because it is always going to be a mimicker. We do see children beyond 6 months of age who are having recurrent symptoms. Always rule out mimics. Investigation is mainly done to rule out mimics. History and examination still and always seems to be foremost, very important. Before this session ends, I just like to demonstrate a small video how to use the inhaler therapy. So this is prior to use, you have to shake the inhaler 5 times. Now, why is it being done? See, what are the components of a meter dose inhaler is that it has a drug which is in micrograms. There is a surfactant and there is also a propellant. The propellant makes up 70% of the inhaler. The surfactant is around 10 to 15% and the rest 10 to 15% is only the drug. So in order for the propellant to mix with the surfactant and drug, you have to shake the inhaler. And the next step, when you are using it for the first time, so this is known as priming the inhaler. So priming means what? You have to shake the inhaler. After shaking the inhaler, you have to press the inhaler 4 to 5 times. Ideally, you have to press it into the spacer. This is done for the inhaled corticosteroid prior to start giving the first dose. Should not be done regularly. However, for SABA, whenever SABA has not been used for more than a week or more than a few weeks, then you should prime before using SABA. This is known as priming the inhaler. So this is priming. However, priming should be done so for a bigger boy, you can follow the, like we see in the video, we can follow a breath holding technique. That is, you give a puff and then breath hold for around 6 to 10 seconds and then release. For a smaller child, you can correlate it with the tidal breathing. For smaller children less than 5 years of age, they should have a mask. Mask is not required for children beyond 5 years of age. and the mask should be tightly sealed, and around 10 to 20 tidal breaths should be there. Child should inhale and exhale, and you match it for around 10 to 20 breaths. Ideal recommendation is 10 breaths, but generally we tend to give it for around 20 breaths. Breath holding can be followed for children beyond 6 years of age. So this is the correct device of the technique of how to use the inhaler. Lastly, how to clean the spacer. That's the safer. So cleaning is when we do is weekly once the spacer should be cleaned. You will dismantle the spacer. The method is called as dip dry method. You will dip in warm water and allow it to dry for around 20 minutes outside. This is called drip dry method. You should never wipe the inner surface of the spacer because it has electrostatic forces and it will disrupt particles from getting deposited there. And you should always remember, after the spacer is used, the patient, if a bigger child means, you should ask them to prevent oral thrush, you should ask them to brush their teeth or take a few sips of water or gargle their throat. For a smaller child, you can encourage giving a few sips of water. This is the correct technique of using the spacer. Spacer should be changed yearly once. So with these scenarios and the current GINA guidelines, and I think we have summarized whatever the aspects of treating a child with under 5. You can just post your questions below, or I'll unmute and you can give your questions so for me to answer them. So you can kindly post your queries either as a question or you can voice your opinion. Next 10 minutes we can spend on having a question answer session. Brittle asthma. Someone has raised the question of what is brittle asthma. Is it common in children? We do definitely tend to see brittle asthma, but the percentage of population whom we see is generally in the adolescent or pre-adolescent age group. The brittle asthmatics below less than 5 years of age, is very minimal. When they tend to have frequent exacerbations and recurrent hospitalizations, even on adequate therapy, usually in an adolescent age group, whose response varies, then we consider them as brittle asthma, and common morely in the adolescent and pre-adolescent age group, not so routinely seen in an under 5 age group. If someone feels that their question is not being answered because I'm not able to hear you, you can post a message here.
முடிச்சிட்டாங்க மீட்டிங். அது 12 to 1 போல.
Someone has raised a question about recent drugs which are used. Someone has raised the question of about recent use of drugs like tiotropium. Tiotropium is to be used only for children beyond 5 years of age. The recommendation is only beyond 6 years of age. It is available only as a mist inhaler. It is only used in step 4 and 5 for adolescent or pre-adolescent asthmatics. There are no the use of tiotropium for children less than 5 years of age or less than 6 years of age. With regards to tiotropium availability in India, yes, definitely there is availability in India of tiotropium. In the question, another question posted is, I think Dr. Shailaja would answered your questions. Another question posted is, what about tapering of corticosteroids? Once again, tapering of
நானும் ஒரு கப் எடுத்துட்டு வரணும்னு நினைக்கிறேன், மறந்து போய்.
So question regarding tapering of corticosteroids. So you classify them as inhaled corticosteroids and oral corticosteroids. With regard to inhaled corticosteroids, less than 5 years of age, there is no need for tapering your inhalers. That is your Budicort. You can stop it abruptly. Only beyond 5 years of age, you have to taper the inhaled corticosteroids. You have to taper and stop over 3 to 6 months depending on the condition. Other thing is, for oral corticosteroids, you give oral corticosteroids only when there is an exacerbation. So the duration of therapy for an exacerbation for an oral corticosteroid is going to be anywhere between 3 to 7 days. So when you are giving steroids for less than 10 days or less than 14 days, there is no need for tapering the oral corticosteroids. We have 5 more minutes left. If you can, if you have any queries, you can post your queries. Dr. Shailaja has asked a comment on, they heard some about medicated nest or room where the child is placed and not exposed. To my knowledge, there is no as such recommendations of using such medicated nest or in a room where the child is exposed, not exposed to the other environment and is placed in the medications or the medicated nest like environment. There is no as such recommendations to use such in under 5 age group or even above adolescent age group. Particularly for smaller children is the question which I was. There is no recommendations as such for use. There is another question which is being posted. Will lactose intolerance exacerbate Wheeze? No, lactose intolerance, there is no association between lactose intolerance or Wheeze exacerbation. This you can have other, it is just an intolerance. Only it is not an allergy per se. When you have milk protein induced allergy, cow's milk protein allergy, there you can consider an exacerbation of which can occur with this. But it is just an intolerance and not an allergy to lactose. So lactose intolerance and these exacerbations, there is no such big an association or no association at all when compared to cow's milk intolerance. What are general combinations used with starting doses, please? So the question is, what are the general combinations which is used? Inhaled corticosteroids, the general combinations used are, Indian scenario, we commonly use Budicort 100 microgram MDI. It is called pressurized MDI. Budicort 100 1 BD for 3 months is the one which we use. Doubling is Budicort 100 2 BD for the next 3 months if there is no control. So Budicort 100 1 BD is a recommended dose. Currently beclomethasone is also available. It is available as Beclet 50 1 BD you suggested to start use. The recent GINA guidelines mentioned the use of fluticasone propionate. It is available as Flohale 50. It is called Flohale 50. It should also be started on the dose of 1 BD for 3 months. So Flohale, Beclet, Budicort are all the common inhaled corticosteroid currently available in market. Last we'll close. Is there any no more queries? We'll close the session in another few minutes. Very good question again posted, like how long can we use steroids without arising of complication? It is, see, low dose inhaled corticosteroid, they have done studies comparing child with Wheeze who is on low dose steroids and comparing another child who is not on inhaled steroids. Low dose, the final difference in the adult height between those two children were only 3 centimeters. So low dose steroids are not going to affect your height, are not going to affect any major long-term side effects of steroids. However, when you are using moderate or high dose steroids, you have to monitor height, eye examination has to be done, and other features of Cushing's syndrome are all to be looked off in children who are on medium to high dose steroids. Growth plotting is very mandatory for such children. With low dose, there is very marginal difference in the final height. How long can we use steroids? See, it's a very the percentage of population of children requiring medium dose steroids for under 5 age group is very few. The percentage is going to be very few. So majority of the children outgrow Wheeze. Only 20% continue to remain asthmatic, and the difficult asthmatics belonging to the step 4 are very minimal in the under 5 age group. Most of the times there is a problem in comorbid triggers or in the technique of usage of the inhalers rather than the disease per se. I thank one and all for joining us in this session. And hope your doubts have been answered. I apologize for the minimal interruption half an hour before due to some technical issues. Thank you very much. Have a good day.